The most important study that was presented was a study called PRODIGE 24. It was presented by a French and Canadian group. And up until recently, the standard of care for patients with resectable pancreas cancer in the adjuvant setting was treatment with either single-agent gemcitabine, single-agent 5-fluorouracil, or a combination of the two, combination of gemcitabine and capecitabine. However, in the metastatic space, we know that more active combination chemotherapies are more effective, especially a regimen called FOLFIRINOX. And so this study was designed to try to answer whether giving patients with resectable pancreatic cancer FOLFIRINOX in the adjuvant setting would be better than gemcitabine alone. And the study definitely proved that it was a very clear-cut result. Patients who received FOLFIRINOX after surgery lived longer, and their disease recurred at a much lower frequency. So based on this study, I believe that the standard of care should change. Patients after surgery and who can tolerate a more aggressive chemotherapy should receive FOLFIRINOX chemotherapy. There are still some unanswered questions, so many patients cannot tolerate this aggressive chemotherapy after surgery. And is it possible for us to develop ways of delivering the chemotherapy safer and more effectively? And that ties really well into the second impactful study that was presented. This was a study called the PREOPANC study. It was presented by a Dutch group. They were studying whether giving chemotherapy and radiation before surgery, followed by chemotherapy after surgery, was safe and effective compared to just getting chemotherapy after surgery. The bottom line was they found that it was in fact safe and effective, and perhaps even more effective than just getting chemotherapy after surgery. This, together with a number of other studies that have been published recently, suggests that moving systemic therapy earlier in the treatment paradigm for patients with resectable pancreas cancer is safe and perhaps even more effective than receiving systemic therapy only after surgery. And so I think between these two studies, a number of other studies, the way that we treat resectable pancreas cancer is going to be changing and evolving quickly over the next few years. We're going to be giving chemotherapy earlier on, oftentimes before surgery, and perhaps even integrating radiation therapy for selected patients. Beyond pancreas cancer, there was also one study looking at pancreatic neuroendocrine tumors, a different kind of pancreas cancer. Many of us use a combination of chemotherapy called capecitabine and temozolomide, but without really strong evidence. So a study designed and conducted by ECOG demonstrated that this combination was indeed effective and safe for patients. So although it doesn't change our approach to treating pancreas neuroendocrine tumors, it definitely provides us with stronger evidence that this chemotherapy combination is effective. Finally, there was one study looking at a drug called ramucirumab, which targets the VEGF pathway in liver cancer. So in patients after failure of standard frontline therapy, this study showed, it's called the REACH2 study, showed that ramucirumab is modestly effective for patients with elevated alpha-fetoproteins. It doesn't also change the paradigm because the effect was modest, but it definitely shows that the VEGF pathway is an important target and supports evidence of other drugs that are also targeting that same pathway. So these are the studies that were most impactful presented at this year's ASCO annual meeting.